and good afternoon and good evening to all of us who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Shankara Panisha from Birmingham, UK. And he's going to lecture us on treatment landscape of CLL in 2024. This webinar is brought to you by Mumbai Hematology Group, supported by Lucien Life Sciences and managed by Perfect Square. I thank Mr. Srivastav and team Lucien, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Padmaja Lokireddy from Hyderabad, our guest speaker for the day, Dr. Shankara Panisha from Birmingham, UK, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, and evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 27th of April 2024, from 7 p.m. Indian Standard Time and 8:30 a.m. Central Time, we have a webinar on malignant histiocytosis, unraveling the challenges in histopathologic diagnosis. And the guest speakers are Dr. Aishwarya Ravindram from Birmingham, USA, Dr. Dana Fournier, and Ms. Kathy Winsky, the Histocytic Society. And the following day, that is Sunday, 28th of April 2024, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on novel drugs in MDS by our guest speaker, Dr. Maria Diaz Campello from Spain. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from Zydus Hospitals, Ahmedabad, Dr. Amba Garg from DKS Hospital, Raipur, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Ashish Dixit from Manipal Hospital, Bengaluru, Colonel Dr. Ashok Meshram from Command Hospital, Kolkata, Dr. Bharat Parikh from HOC Vedanta, Ahmedabad, Dr. Bhavin Shah from Vedanta, Ahmedabad, Dr. Bilal Qazi from Apollo Multispeciality Hospital, Kolkata, Dr. Chandrasekhar Bendi from Mahatma Gandhi Cancer Hospital Research Institute, Vizag, Dr. Chirag Shah from Apollo Hospitals, Ahmedabad, Dr. D.S.K. Sahitya from Medicover Hospitals, Vizag, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. A.R. Jaswantini from Yashoda Super Specialty Hospitals, Hyderabad, Dr. Khushbu Jain from Medicover Hospital, Aurangabad, Dr. Malini Garg from Homi Baba Cancer Hospital, Varanasi, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Mona Vijayaran from SGPGI, Lucknow, Dr. Nidhi Jain from Zydus Hospitals, Ahmedabad, Dr. Nilesh Vasekar from Medicover Hospital, Nashik, Dr. Pujita Bayoreddy from Care Hospitals, Hyderabad, Dr. Priyanka Srivastav from Baikaka University, Karamsad, Dr. R. Prasanna from Cancure Cancer Center, Tamil Nadu, Dr. Rajan Yadav from GCRI, Ahmedabad, Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital and Research Center, Madurai, Dr. Ravi Kiran Bonanthia from Hassan Institute of Medical Sciences, Hassan, Karnataka, Dr. Rudra Narayan Swen from PGI, Chandigarh, Dr. Sandeep Shah from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Sanket Shah from HOC Vedanta, Ahmedabad, Dr. Saroj Bala from AIMS, Raipur, Dr. Satish Kumar A. from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Shailesh Lavana from Kailash Cancer Hospital Research Center, Goraj, Vadodara, Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik, Dr. Sudarshan Pandit from Ashoka Medicover Hospital, Nashik, Dr. Sushil Selvarajan from Christian Medical College, Vellore, Dr. Tilakavati Venkatesan from VS Hematology Oncology Clinic and BMT Center, Chennai, Dr. Tribikram Panda from Artemis Hospital, Gurgaon, Dr. Tushar Pandey from IMS and Some Hospital, Bhubaneswar, Dr. Yashwant Kashyap from AIMS, Raipur, Dr. Yi Mountain from North Okalapa General and Teaching Hospital, Yangon, Myanmar. Now it's the time to introduce our very special guest for the day. We have got our chief guest, Dr. Padma Lokireddy from Hyderabad. Dr. Padmaja Lokireddy is a clinical hematologist, hemato-oncologist, and bone marrow transplant specialist at Apollo Hospital, Jubilee Hills, Hyderabad. She is a clinical hematologist, hemato-oncologist, and bone marrow transplant specialist at Apollo Hospital, Jubilee Hills, Hyderabad. She also sees outpatients on on-call basis at Avasa Hospital, Manikonda, Hyderabad. She completed her MBBS from Devraj URS Medical College, Kolar in 1998, DNB General Medicine from Manipal University in 2003, and MRCP UK from Royal College of Physicians, London, UK in 2008, and FRC Path Hematology from Royal College of Pathology, UK, and been on specialist register with General Medicine Council, UK to practice specialty as independent consultant in UK. Before returning to India in 2015, she spent time in Johns Hopkins Cancer Hospital, USA, worked as bone marrow transplant consultant at Queen Elizabeth University Hospital, Glasgow, University Hospital, Birmingham, UK, as consultant hematologist at Ipswich Hospital, a part of Cambridge, and University Hospital, Leicester, UK. It's our pleasure to invite Dr. Padmaja Lokireddy to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Padmaja Lokireddy.
Thank you, Doctor, for the kind introduction. I don't see Dr. M.B. Agrawal today. Dear colleagues, students, and young hematologists, I know a lot of young hematologists are part of this meeting. A very good morning to be part of this Sunday morning. And a special thanks to Dr. M.B. Agrawal for inviting me to this lecture event as a chief guest and making me part of his passionate teaching endeavors. And today we gather not only as a professionals in this field of hematology, but also a progressive group ever learning and updating the innovation and breakthroughs. It is crucial to remember the profound impact it is making on our patients' journey. This enthusiasm among the doctors and scientists, which led to these milestones, which again calls upon for the future generation and the youngsters to push the boundaries and pioneer the new treatments that will ever change the future of the history. And we also urge not just being a clinician, also to become a researcher for future generation and bring back those research skills to India and to change the innovations and from get the bench to the clinic in India as part of the Make in India projects. What I want to say, it's not just as a professional development, it's also a personal development. Our career is very challenging. A lot of us are at different parts of our life. Your career path is long, so it's important to balance your personal, professional, and it is not going to be said and done of studies. At the current generation, it is going to be an ongoing, continuous learning. So one has to learn to balance the way to work in their boundaries, in their abilities at this stage. But let us not forget the sight of a human element before going on further, where a person, a mother, a father, or a child whose life hangs in balance. So finding a right balance is the most important thing to have a progressive career and find your support systems, be it work or life. So for you to change, and also it's important to develop a personal development plan for a year on year, as it you're in life or in profession. I think that has helped us, and that's what UK has taught me. My esteemed colleagues and bright minds of tomorrow, I urge you to embrace the challenges that lie around with courage and conviction. Let us approach each day not merely as a practice of medicine, but as challenge of humanity, as shared, continue to be doing the healing, compassion, and excellence. And every day we go to work with that compassion. So I leave the youngsters to have this all throughout their journey. Thank you.
Thank you so much, ma'am, for that great words of wisdom. It means a lot to us. Thank you for joining us as our chief guest for the day.
Thank you.
Let me share the screen again. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Shankara Panisher from Birmingham, UK. We have heard him before also with his fantastic lecture, but it's my formal duty to introduce him once again. Dr. Shankara Panisher is consultant hematologist, honorary associate clinical professor at Birmingham Center for Cellular Therapy and Transplant and University of Birmingham, UK. He's a consultant hematologist with over 2 decades of experience in the treatment and management of blood disorders, including leukemia, lymphoma, and myeloma. He sees patients at the Queen Elizabeth Hospital, Birmingham, the Spire Little Aston Hospital, and Spire Parkway. He earned his primary medical qualification at Mysore University, India, and later earned his degree in general medicine at Bombay University. He then undertook his basic training at the Royal Marsden and Royal Free Hospital, after which he completed his specialty hematology training at the prestigious West Midlands Deanery. He then focused his career on myeloma and venous thrombosis research at Warwick University, where he gained knowledge and expertise in the treatment and diagnosis of those disease areas, in addition to the effective treatment of lymphoma, myeloma, inherited thrombophilia, and stem cell transplant. Upon completion of his research, Dr. Panisha was appointed consultant in 2017 at the Heart of England NHS Foundation Trust, where he has since been appointed principal investigator as well as sub-investigator for several hematolo-oncology clinical trials. He is also actively involved in scientific research and has authored several peer-reviewed articles in renowned medical journals. He has also presented his research at national and international conferences. And today he's with us once again and is going to lecture us on treatment landscape of CLL in 2024. Well, thank you so much. Over to you, Dr. Shankara Panisha.
Thank you, Amit. Only 1 minute. I'm just trying to get my slide. Dr. Kurana, thank you very much for such a fantastic introduction, and always grateful to Professor M.B. Agarwal, not only for instilling the interest in hematology and guiding way back in 93 to 96, but always keeping us in the loop with the hematology. And what a fantastic wisdom of words we had from Dr. Padmaja Loki Reddy, and also inspiring the lot of the future hematologists who will be looking after us in future. With that, I'm going to discuss today the CLL landscape in 2024. I apologize in the election year if there are some slides coming to the politics. So with this background, what I wanted to discuss in the next hour is looking at the frontline treatment of the CLL. How do we make the decisions? We'll have a brief discussion regarding the management of relapsed refractory CLL, and the most important bit is about how do we partner with our patients in making the best decisions. With this, I thought there's no fun in guessing who this person is. This is a name from the past. He was the American Defense Secretary in 2003, and what he mentioned regarding the weapons of mass destruction is so much true regarding science, and particularly where we are in terms of the current treatment strategy in CLL, because none of us were aware all these new novel treatment are going to be with us in 2024 if we were looking at the beginning of the new millennium. So with this, I wanted to, because of the varied audience, just run through a bit of a basics about chronic lymphocytic leukemia, which is the most commonest leukemia in adult, and it is mainly characterized by the typical immunophenotyping, dual positivity for CD5 and CD23. We do used to have Matute score to define with a score of 4 or 5 out of 5, confirming the diagnosis of chronic lymphocytic leukemia. The key is the median age of CLL is 72 years, and only less than 10%, that is 1 in 10 patients, are below the age of the 50. This may be slightly different in different ethnic populations. So in India, you may be seeing a lot more younger patients. And again, like most conditions, it is more common in men as compared to women. And we do know there is a genetic predisposition, and we are also aware of familial CLL, and with the CLL manifesting a decade earlier in the next generation. But this is the one thing which we have changed the natural history of the chronic lymphocytic leukemia. So this is data from Emily Montserrat, which we used in one of our publications. If you can see, before the new millennium, increasingly small proportion of patients were presenting with a BNA C when they were diagnosed. Most of the patients would have been diagnosed because they went to the GP for unrelated things and a routine blood test. Now, if I put the same information for 2024, highly likely less than 3% of our patients will be diagnosed because they presented to a clinician with a symptom, because more and more routine blood tests being done, picking up the diagnosis of chronic lymphocytic leukemia, and majority of patients not needing for a long time. Because as Dr. Loki Reddy mentioned, both history will guide us how do we do in future. So just wanted to run through before we can discuss what is the treatment landscape in 2024, how the CLL treatment has progressed. Not much happened in the last millennium. Suddenly there is a flurry of activity, and now we've got exciting small molecules. So there's all the development is not only in terms of the chemotherapy, but also in terms of the immunotherapy. But with the introduction of the small molecules, suddenly the need for immunotherapy has decreased. But now we do need immune directed treatment for patients who are pathway failures. But what really changed in the new millennium is these two groups of drugs, which is signaling the B cell pathway. So the BTK inhibitors and the BCL2 inhibitors. So we now not only have the one generation, like how Prof. Agrawal say 1G, 2G, same way we have both covalent and non-covalent BTK inhibitors, and we already having the second generation BCL2 inhibitors. So with this background, what I wanted to discuss next is how do we make treatment decisions in patients with the CLL, particularly in the first line. And I think this is a critical decision we need to make, and it is we need to weigh the efficacy versus the side effect of the treatment, and particularly in the settings like India and other countries where health is cost will be borne by the patient, we also have to look into a financial toxicity in terms of making treatment decision. But at least it is wonderful to be a CLL clinician where we have access to so many drugs, but that also leads us to a much more difficulty of how do we make the best decision for the individual patient. So in 2024, what's critical in terms of the CLL is not only our routine assessment, but the molecular markers, and the two genetic information is critical. One is the IGVH mutation status. 50% of our CLL patients will be unmutated. Knowing this is very critical, as unmutated patients have a shorter survival. Their response to the treatment is inferior to the mutated CLL, and also patients with unmutated IGHV do acquire other genetic defects during the natural history of their CLL. So now, before we make any treatment decisions in CLL patients in 2024, access to this IGVH mutation status is critical. And with so many experts on the call, I don't have to mention the importance of the FISH for 17p deletion or the p53 mutation. What I've done is have put number of studies from 2008 to 2020, which clearly highlights the poor prognostic impact of the TP53 mutation. or 17p deletion. And before the introduction of the novel treatment, the progression-free survival in patients with the 17p deletion or TP53 used to be just 2.5 years from their frontline treatment. So we do need to have both the TP53 mutation status and the IGVH mutation status before we make the treatment decision. What I wanted to discuss coming from UK is to run through the BCSH guideline and also to highlight how quickly a guideline becomes not relevant. If this BCSH guideline came up in 2022 and already the first line treatment is outdated because it doesn't have I+V. So with this, I just wanted to run through the BCSH guideline for the frontline management. And I think the key decision we need to make for our patient with the CLL is either an indication for treatment. So this will be based on the IWCLL criteria. Even in 2024, if there is no IWCLL criteria for treatment, there is no indication for treatment, and there need to be continue to be watch and wait. I have patients who are I diagnosed when I was first appointed as a consultant in 2007, and now 15, 16 years down the line, they're still not had treatment. And the key decisions we need to do is about the IGVH mutation status and also the P53. In UK, all treatment decisions are based on whether patients are eligible to the FCR or not eligible. And if people are fit to have FCR, then we do have mainly three options: historical chemoimmunotherapy, which would be FCR, but I can't recollect in the last 3 or 4 years when we have offered an FCR. The option will be either venetoclax, obinutuzumab, or I+V, following the GLOW and CAPTIVATE will run through. Whereas if patients are not fit for FCR, then they are eligible to either VO, I+V, or BTK inhibitors. In UK, we have access to both acalabrutinib and zanubrutinib for the first-line treatment. Unfortunately, ibrutinib is currently not available as a first-line treatment. Uh, on the other hand, if patients do have TP53 mutation or the 17p deletion, what BCSH and the ESMO guideline will recommend is a continuous BTK inhibitor would be first treatment option, and venetoclax based time limited treatment would be as a second option. So this leads on to the question, what is the best initial treatment? Unfortunately, in 2024, it is impossible for us to say one single treatment is best because we don't have many head-to-head studies between the different BTK inhibitors in the first-line setting, even though we have the data in the second-line setting. And it depends how do we choose is based on the efficacy, side effects, long-term disease control, and particularly in the Indian setting, we may also need to look at the cost of the treatment. And most important is about how do we sequence the treatment and what options do we have as the second and subsequent line treatment. But there is a few factors do make very critical in terms of making the decision. One is the patient preference. So this would be towards the either fixed duration treatment or continuous. The comorbidities of the patient. If somebody does have a mechanical heart valve and they do need to be on the treatment because of the warfarin anticoagulation, we do know such patients wouldn't be a candidate for BTK inhibitors. And we also need to look at the TLS dose ramping for the venetoclax, and how easy for patients to take part. With this, what I thought I will summarize is the which clinical trials do we have for the frontline management with the BCL inhibitors. So we have three trials looking at the role of BCL2 inhibitors in the frontline management of the CLL. The first one is the German CLL 14 trial. This for patients who are unfit to have FCR, and over 400 patients were randomized between venetoclax, obinutuzumab, and chlorambucil obinutuzumab. We do have last year a follow-up of 7 years presented by Othman, both in the EHA and subsequently in the Lugano, which showed venetoclax obinutuzumab had a significant PFS benefit in all the risk groups as compared to obinutuzumab and chlorambucil. We will look at this data in a greater detail, in spite of a trend towards the overall survival benefit. Even at 7 years of follow-up, there is no overall survival benefit with the VO. Next study was the Captivate, and Captivate had two arms. One is the MRD directed arm, and the other one is the fixed duration. So for the topic of this today discussion, we are discussing about just under 160 patients who were enrolled or randomized in the fixed duration treatment. Now in 2023, Paula Gia did a presentation in the ASCO with a median follow-up of just over 4 years, again showing 82% of the patients who had venetoclax ibrutinib single arm were freedom from the from the next line treatment at 5 years, and a 70% progression-free survival for the whole cohort. The third study is the GLOW. GLOW is similar to CLL 14 in patients who are unfit for the FCR. Patients were randomized between the magic combination of ibrutinib and venetoclax, where patients had an initial 3 months of the ibrutinib, and venetoclax was introduced from the week 13. Total duration of treatment of 12 months venetoclax and 15 months ibrutinib. So over 210 patients randomized with a median follow-up of 58 months, and it clearly showed 3 times PFS benefit to the venetoclax ibrutinib as compared to the chlorambucil obinutuzumab. And again, at the extended follow-up, we do have a overall survival benefit for venetoclax ibrutinib, which is fixed duration, as compared to the chlorambucil obinutuzumab. Just to look at the CLL 14 data in a greater detail, even though in all high-risk group venetoclax obinutuzumab performed well, what do we note in this Kaplan-Meier curve is that patients who have either the IGVH unmutated, 17p deletion, they continue to have a progression, and you can see there is a fall in the response rate in patients who do have an unmutated IGVHV, even though the overall response rate is twice in the VO arm as compared to chlorambucil obinutuzumab arm with over 76 months. as compared to 36 months with chlorambucil obinutuzumab. One, you have a unmutated, the response rate fell to 64 months in the VO arm. And if you do have a P53 mutation, then again the response fell to just over 50 months. So in the multivariate analysis, three factors were associated with the poor performance. One is the lymph node size of 5 centimeter at the initiation of the treatment, AGVH unmutated, and again TP53. Based on this data, that the BCSH and the ESMO drafted their guideline, they do suggest a continuous treatment as compared to time-limited treatment for the patient with the TP53. In terms of the side effects, it is well tolerated, apart from over 50% of patients on the venetoclax having cytopenia and needing growth factor support. And this is the GLOW study, again reiterating the threefold difference in the PFS between ibrutinib, venetoclax, and chlorambucil obinutuzumab. And you can again see, even with the extended follow-up at 57 months, there is a more than threefold difference in the PFS, which also demonstrated overall survival benefit. In terms of the adverse events, they're similar to what we do expect with the BTK inhibitors. Nearly 8 out of 10 patients completing the 15 cycles of the treatment. We did learn a lot from the GLOW study. As you can see in this Kaplan-Meier curve, the red line, which represent ibrutinib, there was a drop in some of the patients in the ibrutinib venetoclax arm, because we were not very good in choosing the right patient for ibrutinib at that point. Now, so much of understanding of the cardiac toxicity of the BTK inhibitors, we are far better in choosing the right treatment. I'm sure some of you may look or ask questions regarding the poor survival among the chlorambucil obinutuzumab arm when their patients were in remission. We will discuss in the question and answer session. I don't want to take too much time on the Captivate study, which again confirmed even in patients who are fit to have FCR chemotherapy. Captivate data showed fixed duration 15 months of ibrutinib and 12 months of ibrutinib showed 70% progression-free survival at 5 years, and 82% of patients at 5 years not needing the second line treatment. And the adverse effect profile is similar to what do we know from the BTK inhibitors in terms of the atrial fibrillation. And you can see, as compared to the patients from other studies, atrial fibrillation rate is less, suggesting this age also has got a significant risk of atrial fibrillation in patients with the BTK inhibitors. We look forward to see much more data from the MRD negative group of the Captivate. With this, we will look at the frontline BTK inhibitors. There were 3 clinical trials of importance. One is the Resonate-2, which clinical utility will be limited in 2024 because it was ibrutinib versus chlorambucil. The criticism being chlorambucil was not a right comparator arm even at that stage. Then Elevate-TN with over 500 patient 3-arm study being acalabrutinib with or without obinutuzumab versus chlorambucil obinutuzumab, and we now have again over 6 years follow-up. We will go through the data in greater detail. This study did show there is a fourfold difference in the progression-free survival between chlorambucil obinutuzumab versus acala and obinutuzumab, and again there was an overall survival advantage for acalabrutinib with obinutuzumab as compared to chlorambucil obinutuzumab. In UK, we only have access to acalabrutinib as a single agent, but the marketing authorization is it can be combined. The next critical study is the Sequoia, which is looked at the zanubrutinib, and you can say the cohort 1, the comparator arm, is a much better chemo immunotherapy, bendamustine, nearly 4 years follow-up showing a significant progression-free survival advantage to zanubrutinib. The second cohort is the patient with the p53 mutation or the 17p deletion, and I will take you through the detail outcome. So this is Resonate 2 clearly showing a significant benefit of ibrutinib, but now I think in UK we don't have access to ibrutinib in the frontline setting. But this is highlighting the Elevate TN, which I explained, the fourfold difference in the progression-free survival for acalabrutinib with obinutuzumab as compared to chlorambucil obinutuzumab. And I think the key point from this is continuous BTK inhibitor. There is no impact of the IGVH mutation status. And again, with the 17p deleted continuous BTK inhibitor, had a much better outcome as compared to the single agent. And you can see here how on the extended follow-up, there is a fourfold difference in the progression-free survival between chlorambucil obinutuzumab and acalabrutinib and obinutuzumab. So this, if we run through the Sequoia data, the cohort 1, nearly just under 250 patients randomized between zanubrutinib versus bendamustine rituximab, whereas just over 110 patients in the single arm zanubrutinib when they had a p53 or a 17p deletion. So what clearly showed at the primary analysis with a follow-up of just over 2 years is nearly 60% reduction in the progression with zanubrutinib as compared to BR. You do need to note that the BR is a much better chemoimmunotherapy as compared to chlorambucil obinutuzumab, and 70% reduction again in the risk of progression. If you look at the overall response rate, again, there is a 10% difference in the progression overall response rate between bendamustine rituximab and the zanubrutinib. In terms of the side effect profile, similar to what we have seen with other BTK inhibitors, and the atrial fibrillation rate is less. We will discuss the side effect profile among the BTK inhibitors later on. But what clearly came across is this, even in patients with a very high risk group of 17p deletion, overall response rate is 90%, and 2-year progression-free survival is 90%. When we had a before all the novel treatment, the 2.5 year used to be the PFS. Now 90% of patients are still on treatment with an excellent remission at 2 years. And the key is that zanubrutinib was superior to bendamustine rituximab in all cohort. The eagle-eyed among you might have noticed, as compared to Elevate TN, where a couple of sections there was no difference, whereas zanubrutinib is in all groups, zanubrutinib was superior to bendamustine rituximab. What I wanted to summarize is um, uh, in across the world now, BTK inhibitors and the BCL2 are recommended as the first line treatment for the CLL. Regarding the individual drug of choice, it is dependent on looking at the patient preference, their own comorbidities, and also looking at the possible the salvage strategy, and combination therapies are being shown to be more beneficial with a limited duration, and we can explore the FLAIR clinical data in the question and answer sessions. As far as the relapsed refractory CLL, we do again have the 3 clinical trials, and I have put here the RESONATE, which is ibrutinib versus ofatumumab with a follow-up of over 65 months. Then the ELEVATE RR, which is follow-up just under 4 years, comparing acala versus ibrutinib. And then the Alpine, which is zanubrutinib with ibrutinib, which is again 39 months. We do know that in terms of the efficacy, there was no difference between acalabrutinib and ibrutinib, but the toxicity was much better with acalabrutinib. We'll explore this a little bit further. Whereas zanubrutinib was superior to the ibrutinib, not only for all group, but also patient with the high risk, even though there was no overall survival benefit. So this is RESONATE showing ibrutinib is superior to ofatumumab. But again, the utility of this data is limited because we don't use ofatumumab nowadays. And again, ibrutinib was superior in all risk group. Side effect profile is what we already know in terms of the neutropenia, infection, atrial fibrillation. But the key trial I wanted all of us to focus was this ELEVATE RR, which is comparing acalabrutinib versus ibrutinib, and you can see in the study almost overlapping Kaplan-Meier curves for the progression-free survival. But what really came across is the side effect profile. The hypertension risk was half in acalabrutinib arm as compared to ibrutinib, and again the atrial fibrillation was significantly better. This clearly shows how acalabrutinib had a better safety profile as compared to ibrutinib. And like what we have observed in our routine practice and also from the RESONATE, over the 3 years, people are on ibrutinib 30%, so that's almost 1 in 3 develops hypertension, and about 1 in 5 to 6 developed atrial fibrillation, whereas the risk of developing hypertension with acalabrutinib is just over 10%. Now, this is a Alpine trial with nearly 650 patients randomized between zanubrutinib and ibrutinib. You can clearly see the overall response rate is 10% better with the zanubrutinib, and again zanubrutinib was much more better outcome, both with IGVH unmutated and also with the 17p deleted cohort. Uh, and you can see with a long-term follow-up of just over 3 years, there is a 30% reduction, risk reduction in the PFS by being on the zanubrutinib as compared to ibrutinib. But once somebody has got a high risk CLL with a 17p deletion, the risk of progression is actually almost 1 in 2, just under 50% reduction of progression. So suggesting in patients with a relapsed CLL, if they do have a 17p deletion, it is better off on zanubrutinib. And this is just looking at the toxicity, and the toxicity is similar to what do we know from both frontline and the relapse. It's again, zanubrutinib is superior in terms not only of the efficacy but also the toxicity is much better than the ibrutinib. I've here highlighted the atrial fibrillation risk and the hypertension risk, which is clearly much better with zanubrutinib as compared to ibrutinib. Again, this curve showing the risk of atrial fibrillation at a median follow-up of just over 3 years is significantly higher with ibrutinib as compared to zanubrutinib. So based on this data, we can say in the relapsed refractory setting of CLL, all BTK inhibitors are effective, but we can say acalabrutinib and ibrutinib have a similar efficacy, whereas toxicity profile is better for acalabrutinib. Zanubrutinib is superior to ibrutinib, both in terms of the efficacy and also in terms of the toxicity. But how do we make treatment decisions in our patient with so much of data and the choice available? This is where we do need to work with our patient, looking at the disease characteristics, age, and mainly about fixed duration or continuous treatment. I know my colleague, Dr. Wandru, did do a session looking at the this question. Then it is about the patient compliance, comorbidities, and also concomitant medication, which will impact on the treatment decision, and then the CLL associated autoimmune complication, and particularly health economies like India, we do need to consider financial toxicity or financial morbidity. So I have put these things into 3 categories: disease-related factors to making a decision, because here we do know efficacy. One BTK inhibitors may be better than the other BTK inhibitor. Regarding the patient-related factors, this may be much more choosing BCL2 inhibitor or a BTK inhibitor. And again, in the relapse setting, our first line treatment dictates, and the duration of the first line remission dictates what do we choose for the subsequent treatment. Now, in 2024, we are lucky we have the combination not only of VO, VR, I plus V, and we can discuss the FLAIR data. I just wanted to summarize between the 3 BTK inhibitors. We know there is no superiority in terms of the efficacy between ibrutinib and acalabrutinib, but zanubrutinib is superior. to ibrutinib, and now there is no head-to-head studies at present between acalabrutinib and zanubrutinib, but the eagle-eyed among you would have maybe looked at a comparative study where acalabrutinib with obinutuzumab was slightly better PFS as compared to zanubrutinib. I wanted to conclude, it is lucky that we have excellent BTK inhibitor option for the treatment, both for the frontline and the relapsed refractory CLL. The second and the third generation BTK inhibitors are well tolerated and very effective, even when there is an ibrutinib intolerance. And the question is all about how do we use different combinations we have in the best management of the patient. With this, I will stop and take questions.
Thank you so much. That was fantastic for giving the overview of entire CLL in 2024. And now we go into the question answer session. And for that, I request all our discussants to please put the raising signs so that we can start our Q&A session with Dr. Sankara Panisha. Yes, Dr. Ashish Dixit, your question.
Very good morning, and I think it was a very good overview. I mean, it's a good revision for us for the CLL. My question was mainly related to TP53 mutated CLL in a relapse setting, post-relapse after acalabrutinib. If somebody is put on venetoclax or obinutuzumab combination and responding well, and young patient, after how many months or how many cycles would you recommend a bone marrow transplant? It's a young patient, very well responded to obinutuzumab and venetoclax.
Great question. Even in 2024, we do, it's an unmet need. So how we do here is we do a response assessment at 6 months, because the criteria is the bone marrow has to be less than 20% infiltration, because if you do have a bone marrow infiltration more than 20%, there is a higher risk of graft failure. So in our own practice is we do a response assessment at 6 months, and it's dictated by the donor availability. And if you have a response where there is less than 60%, we do proceed with the allogeneic stem cell transplant. As far as the UK practice is concerned, if you are using, we can only use VO as a front line. So the second line will be using VR, and unfortunately the VR will be stopped at 2 years. Because it is not an MRD directed, so it is a fixed duration treatment. So that is why the moment we think a patient is have a donor and we do know the response is adequate, we proceed with the allogeneic stem cell transplant for the TP53, because we know that if you miss the boat, and even though pirtobrutinib is around the corner, but we did had a compassionate access to pirtobrutinib, but following the FDA approval, both for the mantle cell and for the third line CLL treatment, that compassionate access has stopped. So we don't have a non-covalent BTK inhibitors in UK at the minute.
Thank you. If I may just continue. So what is the timeline that you look at? Like if it is a CLL14 based trial, I mean, that we are basing our treatment on, it will take at least 4 to 6 weeks to reach the full dose of venetoclax. So in that case, the ideal time for transplant will be 6 months or 3 months or some longer, because if you look at the graph, within 2 years, quite a lot of people are going to lose the response.
So I think ideal time, because if you don't have a sibling donor, because only third of the patient will have a sibling donor. If you look at the current, so most likely your time scale will be somewhere between 6 to 9 months because of with the VR. That is what we do here. You will only start the 400 milligram by the 5th week. So that is why the 6 months is the likely time where you would probably get the a good time for an early response assessment. So that is why 6 to 9 months is the best planning.
Thank you very much.
Thank you, Dr. Ashish. Dr. Rajan, your question, please.
Thank you so much for the talk, sir. I would want to go back in technology. I work in a public sector hospital, and I usually don't have access or patients who can afford the fancy treatments. What are your takes on chlorambucil plus spread when nothing works?
And I think it's a great question. What I can say is we didn't discuss with the interest of the time. We can look at the CLL 13 trial from the German group, and where economies we don't have the access. So chemoimmunotherapy may be an option for mutated. If you have an unmutated, and I think then very difficult to persevere with the, but you can clearly say even with 4 drug different combination in the CLL 13, there is no overall survival benefit. There's only progression-free survival benefit for VO or VO plus ibrutinib. So that is why with the available data, we can say if financial constraint, then for mutated CLL, you may offer FCR, BR, or chlorambucil obinutuzumab, whereas for the unmutated IGVH or the 17p deletion, it will be, we will do the best we can do, but it will be a suboptimal choice.
Thank you so much, sir.
Thank you, Dr. Rajan. Dr. Ramesh, your question.
So thanks for the opportunity. It was a nice talk. So my question is for a patient of Raj stage 4 who has got a severe thrombocytopenia, like say for example, platelet is 10,000. So if the patient has got a TP53 mutation, can we straight away use ibrutinib? What is the risk of bleeding in such patients?
Again,
ibrutinib has got some platelet dysfunction issues, so risk of bleeding in such patients who are having severe thrombocytopenia.
Great question. Ibrutinib is associated with easy bruising, and because here we are caught between the devil and the deep blue sea. Unless you clear the bone marrow, you may not get. And one of the thing, if you, from what I heard, it was definitely a stage C with a heavy marrow infiltration. If you had done the bone marrow, and the bone marrow did show some increased megakaryocytes, if there is an immune component to it, you can give a little bit trial of the steroid, because the steroids may give you a slightly increase the platelet count, and then you could start the BTK inhibitors, or our own practice would be with the stage C is probably crack on with the BTK inhibitor with the platelet support, because unless we clear the bone marrow, there won't be any improvement in the platelet count. If we are using steroid with the BTK inhibitors, one thing is to be mindful of. This is the cohort who are at increased risk of fungal infection. So do think of the antifungals, because this is the cohort who are at increased risk of mold infection.
Okay, sir. Thank you.
Thank you, Dr. Ramesh. Dr. Tribikram Panda, your question, please.
Thank you, sir. Sir, excellent talk. So, my question will be, sir, regarding a real life situation as far as the CLL patients are concerned in India. So currently, as far as the treatment modalities are concerned, it's about acalabrutinib with obinutuzumab or venetoclax with obinutuzumab or zanubrutinib, irrespective of the mutational status as far as the treatment modalities are concerned. But in India, we can see obinutuzumab is having a very high cost, and patients they are not able to afford. Number one. Number two, again, venetoclax again not easily available, and financial toxicity and adverse effect. So, what is your take on uh, making a rational and practical protocol of combining the very much available drug with a cheaper rate, that is acalabrutinib, with addition of rituximab for our cohort of patients? Because yes, obinutuzumab with venetoclax, most of our patients they are not able to afford, and acalabrutinib with again obinutuzumab as per elevate, yes, not practically possible as far as finance is concerned. So rituximab with acalabrutinib, what is your take?
Great question. Because I can tell in a different way, because we don't know how much adding rituximab to acalabrutinib adds. So my personal view is I probably would go with a single agent acalabrutinib. I will tell you why. Is because all BTK inhibitors are not the same. Because if you look at the data, rituximab did not add anything to the ibrutinib. So that is why the IR arm in most clinical trials were suspended. And single agent ibrutinib, we can only say the obinutuzumab is probably the better anti-CD20. Now, it is difficult because you give obinutuzumab at a higher dose than the rituximab. The rituximab is 375 and then 500 milligram meter square, whereas obinutuzumab is, but still the data is, we know obinutuzumab is the best anti-CD20 as far as the CLL is concerned. Whereas the benefit of even obinutuzumab adding to the acalabrutinib is marginal. So that is why even in UK, NICE has only approved single agent acalabrutinib. So we don't combine acala with obinutuzumab. And if you are concerned about financial toxicity with a questionable benefit of adding rituximab to acalabrutinib, maybe the single agent acala may be better, because now the only thing is what we do know is the continuous treatment, and there is a 75 to 80% chance this patient may still be on acala at 8 years based on extrapolation of the elevate TN data for frontline.
Okay, sir. Thank you. Thank you, sir.
Thank you, Dr. Panda. Dr. Saiti, your question, please.
So that was an interesting talk. My question is, when you use venetoclax in CLL setting, do you encounter cytopenias like when we use in AML, and how to tackle ven-induced cytopenias?
Great question. I know I quickly brushed over the slides because in our practice, at least 40 to 50% of patients who are on longer term venetoclax do develop cytopenia. And I think good majority of them are some form of growth factor, so probably GCSF once a week or twice a week. And I think only minority of patients had to be on a dose-reduced venetoclax because of the cytopenia. So the options are growth factor support, and if that doesn't do, in others is to reduce the dose from 400 to either 300 or 200. We do have a few patients who can just only be on 200 milligram of venetoclax because of the effect on the blood count. So those are the two options. And we have hardly any limited number of patients on a longer term venetoclax, because most of our regimen will be either VO, where they stop at 12 months, or VR, where they stop at 2 years, and so that we can re-challenge them. So maybe one way And I think the previous caller also asked a very interesting question, the financial toxicity. The best way of limiting the financial toxicity from the Indian setting is probably using the combination and having a fixed duration treatment. Because in spite of the things I mentioned regarding the CLL14, even at 7 years, the overall response rate, irrespective of the group you take for unmutated, 64%. That means 3/5 of the patients are in remission at 7 years. And even if you take the 17p or p53 deleted, 50%, 1 in 2 are still in remission at 7 years. So that is why by having just 12 months of treatment, it is as long as we counsel patient about this risk, it is if financial toxicity is the main thing, we could use the data in terms of our treatment planning.
So the follow-up question is, what is a minimum duration you consider after stopping when obinutuzumab, re-challenging them again with when, in case of
another great question, because if the remission is less than 12 months, then very little point in re-challenging. But if it is more than 3 years, is more likely. But anything between remission status just over 12 months and 36 months, may be better off trying a different agent, because intrinsically what it may mean that either they got a BCL2 resistant mutation. So it would be better off going if they had a venetoclax based to probably BTK inhibitor based treatment or a combination, so that you can, even though all the combination at the minute are at the frontline setting, but hopefully with the new data emerging, we may be able to have the combination of BTK and BCL2 in the second line setting as well.
Thank you. Thank you so much.
Thank you, Dr. Saijay. Dr. Ashok Mishra, your question, please.
Thank you, Professor Shankara, for a very lucid and elaborate discussion on CLL. My question is regarding BTK, the patients on BTK inhibitors, and they develop infections. So how do you manage? Do you stop the BTK and when to restart? And do you use any prophylactic antibiotics for patients on BTK?
Great question. We covered, it may be very wonderful even in the Indian setting, because if patients do have a steroid and they need to be on the BTK inhibitor, so there's a definite risk of fungal infection. And if people are on antifungal infection, you can actually reduce the dose of the BTK inhibitor because of the interaction. So that is one thing. But whenever we initiate BTK inhibitors, we always put them on PCP prophylaxis with cotrimoxazole, and they're also on the for both from the point of the shingles, there will be an acyclovir. My own practice is to continue both until CD4 count is persistently more than 300. So most patients would be for about 6 to 12 months on this treatment, and either you can, because I've adopted our own transplant practice into it, so that is why it's an objective way of knowing with the CD4 cell count. If people do come in with an infection, including during the COVID time, we always stopped the BTK inhibitors, because not only from the point of the infection, but also some of the COVID treatment do increase the level of the, because of the drug interaction, they increase the level of both BCL2 and the BTK inhibitor. So I think ideally, we should stop the BTK or BCL2 inhibitor until there is a resolution of the infection, and then reintroduce. But giving PCP and acyclovir prophylaxis, I think is mandatory. And if people do have a and need for a significant steroid, giving posaconazole or whatever the local antifungal prophylaxis is good. And because of the interaction between the BTK inhibitors and the antifungal, you may need to dose reduce your BTK inhibitor. That's one way of giving acalabrutinib 100 milligram and reduce the financial toxicity.
Thank you. Thank you very much, Professor.
Thank you, sir. Dr. Panisha, on the same note, this is only true with COVID infection or any viral infection? The dose should be reduced of BTK inhibitor?
It's a very interesting question, Amit, you're asking, because there is infection, it will give rise to slight lymphocytosis, and when we stop, there is a bit of an anxiety. But because it is interferes with the infection, we know ibrutinib is the only drug which does normalize the immunoglobulin level in proportion of patient. But my own practice is, if somebody is bad enough to come with an infection, I've been stopping the drug until there is a resolution. And unless it is a simple upper respiratory infection, maybe we have been more cautious.
Thank you, sir. Dr. Akanksha Garg, your question, please.
Yeah, thank you, sir, for the wonderful talk. So my question is that if we have to give time-limited therapy to the patient, and which is a better partner with venetoclax, whether it would be when with the anti-CD20 monoclonal antibody or when with the BTK inhibitor?
Akanksha, that's a great question. So this is where your molecular workup may come to use, because if I repeat what we discussed regarding the CLL14, the three parameters were associated with a poor outcome. One is the lymph node size of more than 5 centimeter, and unmutated, or the TP53. So if suppose any of those three are there, then maybe better off combining venetoclax with a BTK inhibitor. But if you do, based on the data we looked at, because if you have a mutated CLL, then you know VO is much better, because with mutated, they did very well, and it's at 7 years when presented, is about 70% of patients are on progression free. So that is why, that is a one way. How do we choose between VO versus V plus others? In UK, we are only being funded or V plus I or I plus V, but I'm sure there will be now, there is a Acala with a venetoclax data will be there, and then BGene, which is behind zanubrutinib, they have their own BCL2 inhibitor. So this data will be replicated with all other BCL2 and the BTK inhibitors.
Okay, thank you so much.
Thank you, Dr.
And I don't know whether in India we get access to Notch1 and also the BRIC3. So again, the BRIC3 mutation, if they do have, they do get a poor prognosis similar to the TP53. So that is why our own practice is that if somebody has got a BRIC3, to again go with a I plus V rather than VO. And there is a conventional wisdom that Notch1 mutation patient, they don't respond that well to the anti-CD20. Again, rather than using a VO in presence of the Notch1, maybe better off using a BTK and a BCL2 inhibitor, we also know the Notch1 mutation patient are the one who are at higher risk of Richter transformation. So that is why you might use presence or absence of the Notch1 and BRIC3 in your decision-making pathway.
So as of now, like for the genomic profile, are you doing it for all your patients or just some selected patients you're doing genetic filing for CLL? I mean, which includes the BRIC and the Notch1.
So in terms of the UK practice, what is mandated is everyone should, at the point of needing the treatment, have an IGVH and the TP53 mutation status or the 17p. But because by doing the TP53, you pick up additional 5 to 6%, so everybody should have a TP53. Whereas in Birmingham, we are lucky, we do have our own panel where we access additional 14 genes, including the BTK resistant mutation and also the BCL2 resistant mutation that includes Notch1 and BRIC3. So that is why, but we are lucky because of our specialist interest, because Birmingham is the home of ATM deletion. So that is why, because of our and the 11q deletion in the CLL was first identified in Birmingham. So that is how we have got an interest in ATM in Birmingham. For that reason, we got an extended panel.
Thank you, sir.
Thank you, Dr. Akanksha. Dr. Saroj, your question, please.
Thank you, sir, for nice update. Sir, my question is like a patient is being treated on ibrutinib. He develops acute interstitial nephritis. We treat with steroids and recovers. Could we challenge with acalabrutinib or we should not, basically?
Oh, that's a great question. Because we don't have any data to say that this covalent BTK inhibitor is overcome if there is a refractoriness. If they progress on it, there is no data to suggest you can use the other covalent BTK inhibitor. But on the other hand, for intolerance, because here you would be putting this as an intolerance because of the nephritis. So this is the definite indication if you wanted to change from one BTK inhibitor to the other BTK inhibitor. But all the three covalent BTK inhibitors, we can't use them if there is a progression, because we don't have any data at the minute. The only BTK inhibitors we can use on progression would be the non-covalent BTK inhibitor.
Okay, thank you, sir. Sir, and any patient with high risk CLL, IPI around 5-6, so should we wait for exact criteria of IWCLL to be fulfilled, or we can start little bit early in such cases?
It's another great question. We do have some patients who have been.
Yes, sir, I still have two patients. That's why I was asking. The patients are having so big nodes, 5-6 centimeters, and no compression. Exact criteria is not fulfilled, but what to do?
So, if it's a very difficult one, sometimes you might have to use the judgment. You've seen them for some time, and if there is a definite, the lymphocyte doubling time is coming down, but not just hit the 6 months, you may embark on the treatment. So this is one of the reasons why we don't do TP53 mutation in people who don't need the treatment, because otherwise you will have a data. Patient knows that they will do badly, and it create a lot of anxiety, because we don't know that if you have a TP53 mutation in the absence for the indication for treatment, whether it makes a difference to the outcome. And the other area of question mark is how do patients with a TP53 mutation between 1 to 10% VAF will do. And the other thing we are unclear, or maybe some emerging, because we have a very, how do I say, plus or minus for the IGVH mutation using a 98% cutoff. It is possible people who may be with an IGVH, which is homologous between 96 to 98%, or between 97 to 98, may also behave slightly like the unmutated. So that is why by having only positive, negative, we may not be getting the best outcome from everybody.
Thank you, sir.
Thank you, Dr. Saroj. Dr. Nidhi Jain, your question, please. You are muted, Dr. Nidhi.
Me?
Can't hear. Yes, now we can hear a little bit.
Yeah. So my question is regarding, am I audible, sir?
Yes, yes,
Yeah,
you are.
we can hear you loud and clear.
Yeah. So my question is regarding response assessment whenever a patient is on BTK inhibitors. So suppose a patient is on BTK inhibitor and even after a year or so, he continues to have persistent lymphocytosis, almost to the tune of more than 100,000 lymphocyte count. But he has responded at other places, like the lymph nodes have gone down, the anemia has improved, the hemoglobin is above 11, the platelet is around 1 lakh. So would you consider continuing the patient on the same treatment? And when would you consider that the patient is not completely responding? So do we change the treatment or make any
It's a great question. Because of this, we do have a category of response called PR with lymphocytosis, or PRL. So if the hemoglobin is normalized, the platelet count is normalized, and the lymph glands are less than 15 millimeter, that patient does fit into the category of PR with lymphocytosis. So then we can continue. And initially, we used to think people with PR lymphocytosis would have a longer duration of response as compared to people who may be achieving complete response, because with the frontline setting, when we use BTK inhibitor, only 20 to 30% do achieve complete remission. And MRD negativity is again very, very small proportions achieved. So the question you asked is exactly consistent with the PR with lymphocytosis. If the lymphocytosis is still more than 50% from the baseline, then it is PR with lymphocytosis. But if it is, you can just, as long as the lymphocyte count is more than 5, but it is less than 50% from the baseline, you can give the label PR with lymphocytosis and continue with the BTK inhibitor.
But if it is more, like, it is more than the 50% from the baseline, like I said that.
It still fits in with the PR with lymphocyte, as long as it is not going up. Because you achieved a level, say the lymphocyte count come down to 10,000 at the peak response level, and then it starts going up to 20,000, 30,000, 40,000. Then that means somebody is losing a response to the BTK inhibitor, because quite a good proportion of patients developed BTK resistant mutation 12 to 18 months prior to become refractory. So that is as long as the lymphocyte count, even though it is increased, but is either stable or decreasing, then you are well within the category of the PR with lymphocytosis and continue the treatment. But on the other hand, if the lymphocyte count start going up, then we are in a difficult territory.
Thank you, sir.
Thank you, Dr. Nidhi Jain. Dr. Ashok Mishra, you have another question?
My question is, since the bleeding risk is one of the side effect of BTK inhibitors, So how long before the procedure to hold the BTK inhibitors, like how long before the dental procedures, minor surgeries or major surgeries?
It's a great question. With the minor surgery, we say 3 days before and 3 days after. Whereas for the major procedures, 7 days before and 7 days after, those the standard guideline. And there is some data to suggest if you have a factor 8 level, von Willebrand factor antigen level, they may be predictors of a bleeding risk. If you're a patient with the CLL on BTK inhibitors, they have a von Willebrand factor of 150% or the factor 8 level of 150%, they're less likely to have a bleeding symptom. So that is how initially people would have been categorized. But the standard guidance is 3 days before, 3 days after for minor procedure, and 7 days before and 7 days after for the major procedures. I think the same is being applied for the non-covalent BTK inhibitors, pertubrutinib as well.
Thank you very much, sir.
Thank you, Dr. Ashok Mishram. Sir, we have some questions from the audience. Dr. Thomas Kuncheria wants to know, he has a patient of 45 years male, CLL, IGHV unmutated, TP53 negative, started on acalabrutinib. After 1 year develops Richter's transformation, goes into DLBCL, given 6 cycles of R-CHOP and now in remission. Would you continue acalabrutinib now?
It's a great question. Because this patient has had a Richter transformation, two critical information is needed. One is, do we have any evidence to say this patient is the Richter's is clonally related or clonally unrelated to the CLL? So doing IGVH mutation status from the CLL and also from the Richter sample would be good, because the outcome for a clonally related Richter's is poor, because the most median survival will be looking somewhere between 18 to 24 months, and looking, if I remember correctly, the age was only 45. So this patient is a potential candidate for allogeneic stem cell transplant. Even in 2024, this patient meets the criteria for a consolidation with allogeneic stem cell transplant. On the other hand, which is less likely, because if the patient has got an clonally unrelated, because the outcome from a clonally unrelated Richter's is better, you could you may not want to consider allogeneic stem cell transplant at that setting because of the 10% TRM with an allogeneic stem cell transplant. So I think the clonal status have a big impact. And regarding the reintroduction of acalabrutinib, it is difficult to justify because patient only had a 12 months, and on acala patient developed a Richter transformation. So that is why unless there is any question mark about the patient compliance to the acalabrutinib, and he was not taking regularly, it is almost we are in the same realm of our CML colleagues looking at the AKD mutation and the response. Difficult to justify going back on acalabrutinib, but my own suggestion would be, if you are not able to identify clonally related or unrelated, may be the right time to consider referral for allogeneic stem cell transplant.
Thank you, sir. That was very crystal clear. Another question from Dr. Thomas Kuncheria. What is your experience with upfront obinutuzumab plus venetoclax in CLL patients with TP53 mutation positive status?
It's a great question. With 12 months of venetoclax obinutuzumab, what we can do is I can again go back to the CLL14, which has got a 7-year follow-up. Nearly 52% of patients were progression-free survival, but unfortunately, people with the TP53, they continue to progress. So that is why continuous BTK inhibitor is recommended. But in an Indian setting where people have to pay for their own financial toxicity we discussed before, it is reasonable to consider VO because 1 in 2 patient will be in remission at 7 years, so which is a significant financial benefit, no need for any prophylaxis. So it's a huge thing. Now we are difficult to be precise, but if you extrapolate the data what we have from in a German CLL 13, where patients had either chemoimmunotherapy, VR, VO, and VO plus ibrutinib, VR was no better than chemoimmunotherapy on any front. So that is why if you are using CD20, better off using obinutuzumab with venetoclax.
Thank you, sir. Another question from Dr. Thomas Kuncheria. What is the significance of deletion 13q14, deletion 11q, trisomy 12 in CLL now?
Great question again. In terms of the now in the era of molecular medicine, this may or may not make much difference if you are anyway are going to use a continuous BTK inhibitor. Where it really made a difference is the 13q is always been thought to be a good prognostic marker, so people had a good survival, unless you had a biallelic 13q. Then the outcome, the uniallelic 13q was 11q being the ATM deletion on the BTK inhibitors or V plus O or V, they done well. The trisomy 12, again, like the notch one, maybe slightly greater risk of Richter transformation. So all this will also coincide, the immunoglobulin gene stereotyping. So that is why the subset may go, if you have a trisomy 12, you're more likely to be in the subset 2 or subset 5, so which do have a poor prognosis, but the novel treatment may have overcome some of the adverse impact of the 11q and trisomy 12.
Thank you, sir. Another question from Dr. Babita Sodi. How do you tackle with peripheral neuropathy, which is seen in 27% of patients due to side effect of zanubrutinib?
It's a great question. I think it's difficult to know whether they're all because of the zanubrutinib. Do the usual assessment to make sure B12 folates are okay, the investigation, because normally we would have thought the BTK inhibitors would be very helpful in overcoming because of the inhibition of the B cell pathway, some of the peripheral neuropathy, if it is due to disease related. We know Waldenstrom, when people do have, once you successfully treat the Waldenstrom, the neuropathy improves. So I think key is to exclude other causes, what may be either now, if we do find sometime in clinical trial, it is difficult to know association versus causation. Because in some of the trials on the placebo arm, there was 90% side effects observed. So that is why it is very difficult to, association doesn't mean causation is one of my answers. And generally, if it is a disease related, with a successful treatment, you would have expected things to have resolved.
True, sir. Another question from Dr. Krishnathan Kannan. How long do you wait for initiating therapy for a newly diagnosed CLL? Number one, do you still go with all IWCLL criteria in 2024? And what is your experience on monoclonal B cell lymphocytosis?
All great questions. Unfortunately, even in 2024, we still have to wait for the IWCLL criteria to be met before we start the treatment. So my colleagues from King's Hospital, London, did do a trial of cyclosporine in stage A CLL, and we also have the data of ibrutinib in the people who don't meet the criteria, showing no benefit. So that is why, in spite of having access to all these exciting drugs, we should say in 2024, there is no indication for treatment unless the IWCLL criteria are met, because there are toxicity, and even though the numbers are rare, ibrutinib did show there is the uh, cardiac death, which is most likely to be a class effect rather than just ibrutinib related, which is a risk of ventricular tachycardia. So I think we need to be mindful. Risk may outweigh the benefit for this cohort, and we shouldn't embark on the treatment. Regarding the question, the MBL, so again, you can classify the MBL into low risk and high risk based on the clonal lymphocyte with a less than 500 or more than 500. And like the MGUS, quite a good majority of patients with the MBL may progress, but we know good 70% of the CLL patient may never need treatment because they have been diagnosed for going to the GP for an unrelated condition, lymphocytosis, leading to a diagnosis of CLL. So the MBL, I think it's more for monitoring. In UK, most centers, they discharge MBL back to the primary care physician for either 6 monthly or annual FBC monitoring.
Thank you, sir. Dr. Sahiti, you have another question? You put your red hand sign. Dr.
No,
Sahiti?
sir. No, sir. I just forgot.
Thank you. So, sir, I finished all the questions from the audience. Any discussion want to ask any other question to Dr. Shankara Panisha? Well, so yeah, Dr. Yi Montant.
Thank you, sir. My question is, any experience of combining R-CHOP with BTKI or venetoclax in the setting of Richter syndrome?
Great question. This has only been done for Richter transformation. We have a study, Phoenix, the diffuse large B-cell lymphoma, then for the Richters, and we also have a study called the Stellar, in which R-CHOP is combined with acalabrutinib. We know the Phoenix in the diffuse large B-cell lymphoma, adding ibrutinib to R-CHOP did not give any outcome, but there appears to be the acalab may be different to the ibrutinib. So that is why there is a study called Remodel A, which is going on in UK, of combining acalabrutinib R-CHOP. We are eagerly awaiting the result, but definitely in Stellar, which is for the people with the Richters, there is an R-CHOP plus acala. So for Richters, is a good role to combine, so more people will get into remission. And depending upon, we discussed before, clonally related and unrelated, once they complete the 6 months of R-CHOP and acala, you can make a decision whether to allograft or not allograft based on their clonal origin.
Thank you. Thank you so much.
Dr. Priyanka, you have a question?
Thank you, Amit. Thank you, Dr. Panisha. Very nice presentation. I just wanted to ask about your clinical experience with the elderly population and xenogratinib. Like, is there any specific toxicity or precaution you would recommend?
So the zanubrutinib, we have mainly the access from the clinical trial because we had a clinical trial called BG 304, which was bendamustine rituximab versus zanubrutinib. And we also had this Alpine trial, which is again ibrutinib versus zanubrutinib. And then we have got a zanubrutinib is only been approved in the NICE in the last 6 months, but we have got a huge experience, compassionate access use of zanubrutinib in CLL, mantle cell lymphoma, and marginal zone lymphoma. And in terms of the toxicity, it is no different to the other BTK inhibitors, maybe much better tolerated than ibrutinib. Definitely the risk of atrial fibrillation is far less, maybe a two-thirds less than the hypertension risk is slightly more than acala. So of all the BTK inhibitors, the risk of the hypertension is least with acalabrutinib. The only specific side effects we came with the zanubrutinib is they do tend to have slightly low hemoglobin as compared to other BTK inhibitors. And when we were using acalabrutinib, the headache was a lot better with acala in the initial few weeks, whereas the zanubrutinib we didn't have. So only thing is maybe to watch out for the anemia. They tend to be run as lower hemoglobin as compared to other BTK inhibitors.
Thank you, Dr. Priyanka. Any other discussion? Well, so there are no more raising signs and no more questions from the audience. Well, sir, thank you so much for that fantastic and lovely lecture. It was very, very crystal clear. Every point you made was very crystal clear. It was always worth listening to you. Last lecture also, that was fantastic. This lecture, fantastic, lovely. What a wonderful discussion. Thank you so much for being with us today. Thanks a lot to you, sir. And I thank all our discussants as well as audience to join this Sunday morning. Meet you next Saturday and Sunday. Thank you so much, sir, once again.
Thank you, Amit. Bye-bye.